Thank you very much for those words of introduction, and I'd like to take this opportunity to thank Paddy and the Council of the College for inviting me to speak, but also to attend this Charter Day, and it's certainly a great privilege to be here. I can't promise that I'm going to be as humorous as one of our former speakers, and I can only undertake instead to try and get you to drinks a little bit quicker and make sure that at least that part of your evening is not delayed. I want to start out with threats. I'm going to start out with essentially Australian experiences. But in Queensland in 2005, an American surgeon was appointed to work in a town of about 40,000 people. He was appointed as the Director of Surgery without due diligence by the administration. He had multiple complaints about his quality of care. A number of patients died. He was eventually charged with manslaughter. And as a result of this, a very eminent Australian jurist, Geoffrey Davies, whom I'm going to refer to quite a lot in this presentation, focused his report on hospital budgets and how target-focused hospital administrators were, about how they failed to undergo due diligence, they failed to check what was an appropriate level of credentialing, and there was a failure for an appropriate complaints system. Unfortunately, the Bundaberg matter was not the only challenge that we have faced in Australia or New Zealand in recent years. A few years later, a 16-year-old girl died in a large public hospital from an overdose of opiates following a head injury from a golf ball. At the time, disillusion in the public hospital system, and I hear it again and again as I travel as president in multiple countries, disillusion with the public hospital system had led to the point where doctors were threatening to walk out, where there was a failure to communicate between doctors and nurses, and there was a great deal of frustration with the system. We've had similar episodes with the King Edward Memorial Hospital in Western Australia about neonatal deaths. And of course, you're familiar with things closer to home, such as the Bristol Royal Infirmary inquiry, the Shipman affair, and more recently, and it's been highlighted today, the Mid-Staffordshire affair. But unfortunately, you guys aren't completely absolved, and I noticed this in the paper when I arrived a couple of days ago. In short, with all of these incidents, colleges and the profession in general is rarely found to be the cause of the problem. But a certain amount of mud sticks to us. And I sometimes wonder whether we sit and let the mud stick and don't do anything about it. And I'll look at the consequences of that in a minute. As clinicians, we've set out from early history to try and differentiate ourselves from quacks and snake oil salesmen by showing that our standards and our knowledge were superior to those snake oil salesmen and quacks. We obviously start out with something like the Hippocratic Oath, but in the mid-18th century, we had Thomas Percival, who was so upset at the quality of care provided by his colleagues during an epidemic in Manchester that he wrote a code of ethics for clinical practitioners. I think at this point we actually need to understand some of the terms we're going to use, and I appreciate that there is a plethora of definitions around these subjects. But if we can work on something that's very simple, that as a profession we enjoy a monopoly over specialised knowledge, that we expect to be autonomous and self-regulate ourselves, that we have an altruistic service to individuals and the communities that we live in, and that we are responsible for obtaining and maintaining our professional skills, that is a very workable definition for a profession. In turn, professionalism refers to the cognitive, the moral and the collegiate aspects of those professionals. and it connects the core values of that profession to the expectation of the community. I suppose I should expand that a little bit further, that our profession is based on mastery of a complex body of knowledge. We practice it allegedly in the service of our community, of individuals and the community in general. That we have a certain code of ethics by which we practice our profession, and we are committed in turn, through that code of ethics, to competence, integrity, morality, altruism, the promotion of the public good. And whether we like it or not, we consequently have a social contract between our profession and the society where we practice. And the society, in turn, allows us to regulate ourselves as a profession. And it is that opportunity to self-regulate that is the greatest threat to us as a profession, because we are accountable to that society, and increasingly society is doubting our commitment. Over the last 20 years, we've had a plethora of codes of conduct and ways in which we should practice professionalism. But they come down to three core values, which is the primacy of patient welfare, patient autonomy, in other words, the patient's opportunity to participate in their healthcare, and social justice in general. As I said, we have seen a plethora of definitions, codes of conduct, codes of ethics. Almost every professional organisation, particularly the colleges and other medical groups, universities and hospitals, have sought to try and outline or define what they see as appropriate in their membership, how they might handle breaches of that behaviour. My own college expects that all surgeons recite on receiving their fellowship a code of fellowship. In turn, we have a code of conduct. And if you breach that code of conduct, then you have to sign a statutory declaration saying that you understand the consequences of that. So, as organisations, we're becoming much more aware, not only of the individual's need to be professional, but the need as a collective group of individuals to respond to society's expectations. So have we, as professional organisations, responded appropriately? The initial response, it appears to me, for colleges, hospitals, universities, whatever, around the world, has been to get together an eminent group of individuals, to write some form of report and sit back and say that we have defined the problem and now we expect our fellows to act on it. And society, you should be very pleased that we have done just that. The Royal College of Physicians in England put together a working party, and one of their conclusions was that the exercise of professionalism is hampered by the political and cultural environment of health, which many doctors consider disabling. That may well be true, but what are we doing about it? The same report goes on with lots of what I might consider motherhood statements about bridging the gap between science and society and professionalism being at the heart of a good doctor. But what do they really do about addressing the problem for us as practising surgeons? The Canadian College went a little bit further by identifying what it might do about professionalism, and really their approach was to incorporate it into an educational program, and by trying to keep abreast of what may evolve that was relevant to medicine and society. I think it is increasingly recognised that as surgeons, the days of the master surgeon who did everything and was all controlling in the hospital environment in which he or she worked is gone. And I've heard repeatedly in the recent discussions the importance of teams and the teams in which we work. Are we training a surgeon who is appropriate to that new environment? As part of that, that new surgeon has to assume some of the characteristics of professionalism. And so as colleges, the first opportunity for us comes to actually engender a culture of education in our trainees and indeed in our current fellows. And the Canadian College, you'll have seen in one of my earlier slides, actually expects that professionalism is part of your continuing professional development. In doing this, we need to identify what skills we expect a professional person to have, and the skills include how they behave as a professional. We need to adopt a policy about professional behaviour, and importantly, we need to be prepared to enforce that policy. Once again, it is all very well to describe how we cannot accept bullying behaviour, but if we're not prepared to enforce that approach, then we, as professional organisations, are falling down. So, what is covered in trying to teach surgeons and trainees to be professional? There's obviously a knowledge base, a cognitive base around what constitutes professionalism, what are the ethical principles that underpin practice, about risk management for ourselves in terms of health, medico-legal issues, self-regulation of what we do, about teaching our trainees, and about what is sustainable practice, burnout, recognising depression, alcohol-related problems. We also need to teach the skills associated with practising in a professional fashion, which relate to communication and teamwork, time management and things like that. And your college, like mine, has a variety of courses which teach different aspects of professional behaviour, either cognitively or in practice, to your surgeons and trainees. But I wonder whether this is actually enough, and whether or not, as Lucey and Souba have suggested, that we need to do more about actually changing behaviour and having a wider range of tools, particularly to address aberrant behaviour. And recognising increasingly that professionalism is not just a code of ethics, but a rather complex and adaptive process. And some of the skills within it can be taught. So what sort of things are they suggesting to us? Well, we can take a problem like somebody who is behaving as a bully. Now, as the team leader or as the head of department, you might have a quiet word. You might then, when the bullying behaviour recurs, have a formal interview. You might even go so far as to ask that person to have an interview with the director of the hospital. But none of that type of intervention is going to change that person's behaviour unless they recognise that something's wrong. And this is one of the roles that I think we have as colleges, to get our fellows to understand what represents professional behaviour, to understand it is wrong, and to undertake change on a personal and individual basis with a variety of strategies to do that. Let's go back to looking at this as a college, as an organisational perspective. I think we can draw the threads of the conversation thus far together by saying that it can be taught, professionalism can be taught. We can measure and evaluate professionalism. We can try and change the climate in which we work. We can try and, by promote buy-in from our surgeons, and we can try and facilitate dissemination of the process. And obviously, this creates opportunities for us as organisations to teach professionalism, to learn professionalism. And we need, obviously, to look at the systems which impede our ability to do just that. But as professionals, we are leaders in the healthcare system. The Bundaberg situation I referred to shows just what happens when appropriate leadership is lacking. So how do we show as professionals that we are legitimate leaders? I think we need to really demonstrate, not just to our peers and to our colleagues in hospitals, but to government and its jurisdictions, that the care we offer is evidence-based. It was interesting in the discussions that you just had, where you were talking about cancer being focused in 8 hospitals. And I don't want to get into the politics and the individual perspectives on that. But I come from a state with 6 million people, not a particularly different population. And our Cancer Council has actually looked at outcomes across the state. If you have an esophagectomy outside one of our major teaching hospitals, your chance of dying is much higher. If you have a pancreatectomy outside those hospitals, your chance of dying is much higher. If you have rectal cancer outside those hospitals, your options for treatment and your likelihood in which you will receive preoperative chemotherapy where appropriate, or radiotherapy where appropriate, and your chance of having a stoma is much higher or much lower, depending on the issue. But we have also shown that good general surgeons in small hospitals do excellent colectomies, and that answers the question that was put forward about screening. And that good general surgeons treat breast cancer extremely well. And that's very powerful data that has been accumulated by clinicians and which drives policy. And I'll get onto that in a little bit of time. As colleges, we've also got to start dealing with the tough issues, and I talked a little bit about enforcement before. It's all very well to sit back and talk about continuing professional development. But what are you going to do if Surgeon A doesn't do continuing professional development? You know, we sit back and say, oh, yes, 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 we all do continuing professional development. But as an organisation, have we taken the hard choice and say, if we don't do it, you're going to lose your fellowship and the consequences that go with it? And I think these are some of the threats to our organisations if we're not prepared to take those difficult decisions. And we need to rebuild the bridges with the management of our healthcare institutions, because we do need to work as a team with them. Increasingly, the surgical share of the medical budget is decreasing. And yet traditionally surgeons have punched above their weight in the hospital systems in which we work. If we're going to continue to do that, we need to be able to work with management. But I mentioned this tension about, yes, we know we're doing the right thing. In other words, the CPD argument. We want everybody to do CPD. It's compulsory in our college. Or we are going to do the right thing, which is we're going to chuck people out if they don't do CPD and have a process to do it. And that's a tough thing for a collegiate organisation, because we're actually fellows for college and we don't expect the club we belong to act like that when we don't abide by what is considered appropriate practice. So, whilst individuals have responsibilities, increasingly the organisation has to take on a collective role for all of those individuals. Can I go back to those first few slides? 100 years on after Flexner was asked to consider medical education in the United States, which at the time had a plethora of medical colleges, which might be somebody teaching medicine in a small village in a small state, right through to prestigious 100-year-old institutions, he strongly focused on the professionalism of doctors as a way of demonstrating that they were indeed the professionals that society expected of them. Well, what about Stephen Brolin, who actually had to leave the country he worked in because he questioned the outcomes in the hospital where he worked? Or Geoffrey Davies, who looked at the challenges of our system and said we're not doing a good enough job, and forced us as surgeons in Australia and New Zealand to consider where we are. And I suspect that all three of those men would say, yes, Mike, they're great words and we agree with you, but you're not going far enough. You're not fully appreciating what the problem is. And I think the problem is culture. We have a strategy about how we're going to deal with professionalism, and I think I've outlined that. But we haven't changed the culture in our organisations. And until we do that, we're not going to win this battle. And that's the point that Geoffrey Davies has repeatedly made as he talks to surgeons in Australia about our response to professional change. Somehow our wish to be autonomous, to self-regulate, needs to be balanced by the fact that we are in increasingly complex societies, and that whether we like it or not, in the last 30 years, government has taken an increasing interest in our profession. In other words, self-regulation will only take us so far, because the public and policy which pertains to the public is now saying we can do it just as well, or we can do it on our own terms, so why do you need to engage? External regulation and self-regulation are always both going to be there. There will be an expectation of both. But somehow I think it's inherent upon us as a profession, and our colleges need to take the lead in this, to make sure that the community understands that we're accountable for what we do, and that they can trust that we will ensure that that accountability extends to all surgeons. In other words, we're going to honour our social contract. I want to go back to Geoffrey Davies, who spoke to our orthopaedic surgeons in a James Pryor lecture. And he said to them, as surgeons, you have an exclusive right to practice in a defined area. You have a right to professional autonomy, and you have a duty, individually as orthopaedic surgeons and as a group, in Australia that's the AOA, to put the interests of your patients ahead of yourself. And this is your duty of public service. Increasingly in the community, there is a very close relationship between what the public thinks and how the media and the government will think, and in turn how they will respond. And whether we like it or not, and I can't judge what happens in the Republic, but talking to my colleagues in the United States, in Great Britain, and in Australia and New Zealand, there is a perception that many surgeons are greedy, they're obstructive to change, their standards are unsatisfactory, they are unwilling to regulate themselves, and they are not patient-centric. Now, those are the words of Thomas Dean, who's a surgeon in the United Kingdom, but that perception rings true to me. It may not be true, but it's a perception. And Dean called on us to develop a triangle of trust between the profession, the public and the government. And if we're going to maintain our autonomy and our monopoly, we need to do this. I'm still talking motherhood statements, aren't I? Let's get down a little bit more to nitty-gritty and say that as a response to those incidents in Australia, we had a Health Practitioner Regulation National Law Acts 2009. Now, I put a lot of points on that, but basically, once upon a time, when I renewed my registration, I paid my cheque, I signed my form, and that was it. Not any longer. Now the government wants to have proof that I undertake continuing professional development. It wants to have proof that I have medical indemnity insurance. It wants reassurance, not yet proof, that I haven't got any adverse findings against me by something such as the Health Complaints Tribunal. So all of a sudden, the environment in which I work, where I was trusted to regulate myself, has been taken away from me. So whether we like it or not, external regulation is increasingly there, and I'm sure there are parallels in the Republic. Davies called on surgeons, and in particular, as I said, orthopaedic surgeons, to do two things. He said they needed a system of peer review which showed competence and conduct which will withstand public scrutiny. And he said that practice within the whole scope of the profession at the present time tends to reflect a tendency to specialise in lucrative aspects of practice. And this was a public perception of greed and self-interest. He went on to call for better systems of audit and peer review, but not just expecting surgeons to undertake audit or peer review. He didn't ask that the colleges undertake credentialing, and I think that's appropriate, but we need to be appropriately credentialed in our institutions. More importantly, we need to start gathering data. And I noticed your NOSA unit, which is starting to gather data about hip fractures and joint replacements and trauma registries and things. But it goes beyond the collection of data. And one of your previous speakers in talking about NOSA went on, in fact it was Paddy, to raise the question of the public release of surgical outcomes by individual surgeons. I recently attended a quality meeting in Australia, and there was a vote about whether or not surgeons would agree to this. Interestingly, the outliers, the ones who refused to countenance it, were all young, recently qualified surgeons. The older surgeons seemed to have accepted that this was coming and this was going to be part of their professional life. But essentially, we need to be seen as a profession which identifies and, if appropriate, remediates the outlying surgeon. Is it possible? And constantly, as president, I get told why it's not possible. But increasingly, there are some examples of where audit is used in a positive way to influence surgical practice. In Australia and New Zealand, the Vascular Society have made it compulsory for all members to undertake audit. And that required a constitutional change to their organisation. But they measure themselves against their peers, they access their personal results, their results are published but not identified, and outliers are remediated. And they know they will be remediated. But the important part of compulsory is that it's often the outlier who doesn't participate in a voluntary way. And I believe that we can take leadership as professional organisations in giving the public back its trust of how competent we are as professionals. I also think that we have a responsibility to ordinary people. And this perhaps may not be as relevant in Ireland as it is in Australia. But we have increasing examples in Australia of ridiculous fees for operations that may not be necessary. We've had a number of complaints from people with in situ prostate cancer who have been told that you require a radical prostatectomy. They say they have no health insurance. They're charged 25,000 Australian dollars for the procedure. They frequently mortgage their home to have this, and they're not informed that this may not make any difference whether they have this done next week as a private patient or go on the waiting list. Or the surgeon who's sitting in his office or his outpatients who sees a patient and says, "This is a very difficult and complex procedure, Mrs. Smith, and I'd be delighted to do it for you in the private sector, or I can put you on the public hospital waiting list where you'll be for 12 months and my registrar will do the operation. I'll be around if he needs me." This is the type of behaviour, like it or not, that some of our colleagues exhibit and is not fair and not equitable. It does not do justice to what we expect of a surgeon. And until we get this sorted out, we will not be taken seriously by the community. And we need to be culturally sensitive. Again, you have a much more uniform society, but Australia is a country made up of people from all over the world. In my own case, most of my roots, my genome is from this particular island, so I was delighted to be here. I might add that my antecedents probably had one foot in the bog because most of them did not travel first class to Australia. As we develop this theme of professionalism, as organisations, as colleges, I think we've discovered the theme. We've tried to define it, we've tried to assess it, we've institutionalised it within our organisations, and I think we've undertaken the fifth step, which is to try and modify individuals and modify our structures and identify the environmental factors which shape professionalism. I'm not sure yet whether we've fully recast the actors, the structures and the environments in an interactive and adaptive fashion. Moving from the individual to the team and enlarging partnerships will be part of this journey. And until health-related organisations, including colleges, realise that they have to be part of this complex adaptive system, we are going to struggle to be recognised by the jurisdictions. I suspect that both the English College and the Australasian College suffered in the way in which they responded to the incidents which occurred, which did not actually reflect poorly on one of their own trainees or doctors, in our case. But we, to a certain extent, sat on our hands. And that's the threat to the organisation. Because by sitting on our hands, government feels that it needs to act. I sat next to the health minister of our state at a dinner the other night, and I was talking to her about this. And she said, if I can feel confident that professional organisations are acting professionally, then I can go to the press and say that and I don't have to act. The second any hint arises that the organisation is stifling an appropriate response, then I have to act. As organisations, we need to show clinical leadership. We need to make sure that improving quality of care is the fundamental aim of our profession, and we can make sure that that occurs by feeding back and public reporting of clinical outcomes, for example. We also need to acknowledge that the tensions within a membership-based organisation. As I said, our college recognises that there are some amongst us who think that professionalism is a load of codswallop, who refuse to work within teams, who refuse to behave in a socially appropriate fashion. And that's the challenge to the organisations. And we need to develop role models within our organisations that reflect some of the things that I have talked about. And equally, we need to act in the against the individual who shows inappropriate behaviour. We need to lead by example. When I sat down to think about this, because I believe this is the opportunity in my title, there are not a lot of examples set out as leadership examples by colleges, and almost all of them are North American. These two are hospital-based. But I'd just call to your attention NSQIP, which is an American College of Surgeons program. And NSQIP's probably too expensive for us to adopt in Australia. I suspect that might be the case in Ireland. But what that has done is that a surgeon-owned, college-owned program has provided data about quality, has driven change, and is influencing public policy. And that is the challenge and the opportunity of professionalism for the colleges that we are members of. To me, the opportunity to influence public policy is actually the summit of professionalism. That's where we're really trying to get. And to drive that policy, we need to be respectful of those initial aims those initial parts of professionalism that I talked about before, the primacy of the patient, patient autonomy, and social justice. It's a difficult journey. It's a hard journey to crack. I know as a college president who's tried to get there, and I'm sure Paddy would agree with me. But as organisations, we need to start looking for low-hanging fruit, and we need to publicise our achievements so that we restore public confidence in what we do as surgeons. In Australia, the national audit of surgical mortality is to the vast extent funded by government. But as an organisation, we have not sat down and written a paper for dissemination in the general, as distinct from surgical medical press, that tells the government what great value for money it's getting from those audits. And unless we can do that, how are we going to get more money or get more buy-in from government for some of the other good stuff we want to do? Equally, we need to be there and show our social conscience as organisations. In Australia, with an Indigenous population that is underprivileged, that is one of the obvious opportunities for us to engage with government. And it is interesting that when I met the Federal Minister of Health the other day, I found it quite hard to engage him about general surgical issues. But when I started talking about cultural sensitivity and engaging more Indigenous Australians in specialist healthcare, I got buy-in. And I think this is what our organisations, our colleges, have to do. This is our opportunity, and we can use our professionalism to buy into public policy. So in conclusion, and you're 2 minutes late, so I apologise, surgeons need to develop quality of care. They need to do it with integrity, honesty, compassion. We need to exhibit personal and interpersonal behaviours that are appropriate. And the colleges need to ensure this happens. But I come back to threats because, as Geoffrey Davies said, and he was talking about orthopods, not surgeons in general, he said, "What I have said seems to have sunk like a stone, leaving not even a ripple behind." And that's the lesson, I believe, in this whole argument. Thank you very much.